may know, I'm Dr. Farzad Faroqi, also from Loma Linda Hospital. Is this coming up? There you go. Also from Loma Linda Hospital, Dr. Borna already alluded to the hospital and how many beds we've got. We joined the staff there about 3 years ago, a little more than 3 years ago. Prior to that, we had a pain management specialty group that we ran for over 20 years. But it's great being there now. I'm going to be talking to you guys about one lung anesthesia, mainly placement of double lumen tubes. Just like Dr. Borna, I prepared an hour-long set of slides, and I'm going to be needing to go through them a little bit faster today. So if you can bear with me, I'd appreciate it. Disclaimer, I don't have any relationships or financial things otherwise with manufacturers of any of these devices I'm talking about. Objectives, I'm mainly going to talk about double lumen tubes and one lung ventilation and the anesthetic management of that. Objectives, why lung separation? Why do we need double lumen tubes? Three main reasons. Selectively, we want to eliminate ventilation to one lung or a portion of one of the lungs. Second would be to prevent cross-contamination. And third would be to allow exposure for non-lung thoracic surgeries, such as what we did yesterday with the esophagectomy. Several indications, but some are absolute, and these 6 are probably 7 are the absolute ones. One, to confine infection. If there's airway bleeding in one side, you want to separate the two so that you could at least get some ventilation and oxygenation through the area that's not bleeding. Lung lavage, bronchopulmonary, bronchopleural fistulas, a TE fistula. If you've got large cyst or bulla, you would want to isolate, again, to be able to ventilate and oxygenate the good parts of the lungs, and tracheobronchial obstruction. Other indications include that you would want lung isolation for are things such as thoracoscopy, thoracic aneurysm procedures, lung transplantation, minimally invasive cardiac procedures, and coagulopathic thoracotomy. And I say that that's relative because you may have some surgeons that are able to do some of those without needing the lung down. Lung resections, obviously, you might need it for esophagectomies, such as what we did yesterday, and hiatal hernia repairs, where they might need to go into the thorax to put the ligate the two parts of the esophagus. PDA ligation, coarctation, limited exposure, and vertebral thoracic surgery a lot of times needs one lung ventilation. Obviously, pre-op evaluation, you want to do the same type of pre-op evaluation you would with most patients that are sicker. One thing that may be helpful with most of these patients is pulmonary function testing. Pulmonary function testing, you would want to do some arterial blood gas analysis. One thing that you might want to do with some patients, especially if they're asthmatic or if they have some lung problems, is see if bronchodilators help and do some pulmonary function testing pre and post bronchodilator. A lot of times that'll help you know if there's going to be need for post-op ventilation, and it'll give you some idea of if there might be some post-op complications. PFTs in review, you guys all know what PFTs are. I'll skip through these. One thing, especially with pneumonectomies, if you get these pulmonary function test results, they may indicate high risk, mainly if FEV1 is less than 2 liters, if your ABG PaCO2 is greater than 45 on room air, and if your FEV1 over FVC is less than 50% predicted, and if your right residual volume over TLC is greater than 50% of predicted, those may indicate some high risks. Anesthetic planning, again, nothing out of the ordinary. There may be need for prolonged intubation and ventilation. Pain, if they're dealing with thoracic surgery, maybe a little bit more than usual, so that needs to be taken into consideration. But in general, we're anesthesiologists. We should be able to take care of that. Shouldn't be too much of a difference. Pre-op patient preparation, smoking cessation is, very important. And the patient we had yesterday that we did surgery on smoked the night before. And because of that, we had to actually stop multiple times when we went on 1 lung ventilation and had to go back to 2 lungs because he just couldn't tolerate it. I don't know if that would have changed if he hadn't smoked the night before, but I would think that it probably would have. Beta agonist therapy, inhalers, steroids or inhaled IV. See if you can loosen and remove secretions if possible. Antibiotics and pre-op chest PT education are all important for the preparation of these patients. Smoking, obviously it keeps us in business because everyone gets sick. Keeps us busy, but quitting even 24 hours can decrease post-op complications. So in the past, most people thought if you're not going to quit a week or 2 before, you should just keep smoking. But no, even 24 hours has shown benefit. Full benefit obviously is not achieved until about 4 to 6 weeks. If they've stopped smoking that long, that's the most beneficial. And then the patient needs anxiolytics, bronchodilators, and even DVT prophylaxis if they're smokers. And nicotine is more addictive than the heroin. So it's easy to say, but very hard to do for most patients. Pulmonary mechanics, I'm going to skip that. Most of you know the different zones of the lung. The biggest thing is, this is going to change with supine versus left lateral decubitus versus right lateral decubitus. This is in a patient that's sitting up. Anesthesia and pulmonary mechanics, pulmonary residual capacity. You guys all know all of this stuff. Tubes and devices. The first two I'm not really going to discuss due to time. We'll talk about double lumen tubes. There's 3 main ones that make it. Double lumen tubes, why do we have them? The benefit is there's selective ventilation, also selective suction, and tube stability. Problems, obviously, is that they're huge. And they're also a little bit difficult to put in because of the stylet and the shape that they're made, and they're difficult to position sometimes. This is a typical right-sided tube. At Loma Linda, we've pretty much gone with left-sided tubes for everything now. We are able to isolate with both sides, and if we need to ventilate through the trachea for the right lung, we'll do that. It just seems like the left side isolation tubes are a lot easier to put in, and you also have less problems with them, and I'll discuss that when I show you guys the pictures. These are some of the other devices. I'll go through these a little quicker. There's some easy blockers. I don't know, some of you may have used those. They go through a regular endotracheal tube and can block one side versus the other. Successful placement, obviously, with the double lumen, you can look with a direct visual with a Macintosh, but the easiest way is to isolate one lung and ventilate the other lung and auscultate. Nowadays, though, it's almost standard of care to check with a fiber optic bronchoscope when you put the tube in. And with the left-sided double lumen tubes, usually you go in through the cords, and once you've gone in through the cords, you turn to the left. Some anesthesiologists advocate pulling the stylet at that point. For most patients, you don't need to do that, and the reason you don't necessarily want to do that is the stylet is made so that your curvature is stiff on the endotracheal tube. So once you've gone in and your stylet is angled like this, and you turn it to the left, your stylet is going to actually kind of push you into the left bronchus, left bronchus, and usually about 90% of the time, if you've got the stylet in and you do that correctly, you'll go and place it correctly. Let's see. Choosing tube size. The double lumen tubes are anywhere from 26 French to 41. The majority of the patients in the U.S. use a 35 for the females and a 37 for the males, but I would imagine here maybe you might be able to use 32 and 41 as well. So it's based on gender and size. You want to use a smaller tube. If you have a question about it, you want to use a smaller tube first to make sure that the diameter isn't too big for the patient. This is how you could check fiber optically. Once you put the left-sided tube in, and that's what I'll talk about, you can go into the tracheal portion of the double lumen tube, and you go down, and in the first picture you could see that we could see the primary carina in the middle, and above you could see the right main stem bronchus through the tracheal, and on the left you could see the tube with the blue cuff just barely protruding out from the side of the carina. That's the right placement. Just to doubly confirm that, though, you go further into the right main stem bronchus, and what you'll see is the right upper lobe up at the top. You'll see a secondary carina, and you'll see the bronchus intermedius. When we don't place these left-sided bronchial tubes most of the time and think we're in the right spot, a lot of times what we've done is we've gone into the right main stem bronchus and actually placed the tube in the bronchus intermedius. And what we see with our fiber optic is the right upper lobe. And a lot of times people make the mistake of thinking the secondary carina is the actual carina. To further look at that, then you try to advance your fiber optic into the right upper lobe, and that's what you should see. You should see those three other bronchus. One lung ventilation, obviously you clamp the side that you're checking to the ventilator, and you open it up to see to air, and sometimes you may even need to suction the side that they're doing surgery on, especially if your surgeon isn't using gas to insufflate. You may actually need to help them out. Complication of double lumen tubes, because they're so big, there's always a possibility of trauma, malposition, hypoxemia, especially in most of these patients that are needing to have this surgery. A lot of them don't have good lungs to begin with, so hypoxemia is always an issue. Dental injury, soft tissue injury, tracheomucosal wall injury, all of these are also some other big things that could go wrong with double lumen tubes. Malposition, these are some things that can happen with malposition, inability to isolate, deflate, inability to ventilate, left BLT can migrate into the trachea, especially if you're moving from supine to a left lateral or a right lateral. Your tubes can always migrate, and you always have to worry about that. Hypoxia, confirmed ventilation, 100% oxygen, fiber optic bronchoscopy, CPAP to the surgical lung, PEEP to the dependent lung. And the thing with PEEP, that's one of the things that may be an issue with double lumen tubes and hypoxemia when you've got double lumen tubes to the one side that's being ventilated. PEEP sometimes helps, sometimes doesn't. You just have to play around with it, because if you put the patient on PEEP and you see the saturation go down, you have to decrease it, because as we showed in that lung model, you never know what's going to happen with ventilation perfusion mismatches once the patient's put to the side. I'm out of time. Thank you, guys.
Thank you, Dr. Faruqi. This is a great segue from one lung ventilation to our next